The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, good evening. Warm welcome to today's ISQua webinar on application of research to quality improvement. This webinar will introduce participants to the most effective approaches to evaluation of complex improvement intervention in healthcare, so that the knowledge of theories, effective methods, and implementation strategies can be widely shared. I would like to welcome today's presenter, Helen Crisp, who is currently an Assistant Director of Research in Health Foundation UK. Helen has been managing the Improvement Science Programme at the Health Foundation in UK since 2009, working with leading academics and improvement practitioners to develop an evidence-based approach to improving quality, safety, and value in healthcare. Before this, she worked in accreditation for 15 years, developing quality standards covering acute hospitals, mental health, and primary care. She has been a consultant on national quality initiatives in English, NHS, and in Portugal, Denmark, and the Balkans. Just to remind you that today's presentation will take approximately 45 minutes, and we will leave 15 minutes at the end for any questions that you may have. Please type your questions into the question or chat box provided, and they will be posed to Helen at the end of her presentation. We will also use polls during the session, so your active involvement will help Helen to adapt the presentation to the audience who join us today. Well, sit back, enjoy the presentation, and over to you, Helen.
Thank you very much. Well, hello and welcome to everybody joining this webinar. As Juliana has said, I'm going to be talking about some aspects of research related to quality improvement. And clearly that's a vast topic, so this will be very much at an overview level rather than looking at specific areas of research or how to apply particular findings. So, why would we want to be scientific about healthcare improvement? Well, improvement needs to be as evidence-based as any other aspect of healthcare provision. And we want it to use effective theory-based interventions, methods that have been tried and tested, and any change needs to be demonstrated by robust measures. And over the last 5 years, the Health Foundation has been working with others to build the field of improvement science, making sure that quality improvement work is more grounded in the evidence and proven methods, ranging across academic disciplines that are as broad as medicine, nursing, operations research, statistics, psychology, management, and many more, not limited just to the list I've given. And we're hoping that the quality improvement community will start to take a more scientific approach to recording and writing up their improvement work. And why is that important? Well, it will really help you understand what you're trying to do. Applying research findings, knowing in advance what's already been shown to be effective, and building on that work. It's really important to measure what you're doing in quality improvement work and taking regular checks to see if it's working. And we also want to encourage people to report their work so that what we're learning across the board can be shared and people can benefit from the efforts that are taking place. So in terms of understanding what we're trying to do, if you base this on evidence research that's published, you're going to boost your chances of getting the desired results. And it's recommended that if you're going to start an improvement programme, focus on a well-defined issue. Be really clear about what it is you're trying to change. Research what's been tried in that area, build on the previous work, and it's also really helpful to learn from interventions that are demonstrated as ineffective. Now, there's much less published when people try an improvement approach and find that it's not as effective as they hoped, but we can learn an awful lot from what doesn't work. So, a key problem across many areas of healthcare is infection control and wanting to improve that by improving hand washing rates. So if in your health service this is something that you want to tackle, it's a really good idea to have a look at what approaches have been tried, what's shown little effect, what works, where's the good evidence, what can you adapt from successful interventions that have been well written up, where did it work, and is that a similar sort of place to yours, so is it likely to work for you? So, for example, much of the published work around increasing hand washing rates in the attempt to combat infection has shown that it really needs to be multifaceted and involving two or more components. So, for example, you'd want to have an awareness-raising campaign, plus some staff training, plus some measures of being able to understand whether the hand washing rates have gone up or not. And, for example, information on its own has been proven not to be very effective. So if you just put up posters around your hospital or other healthcare setting, it's unlikely that that will really boost the rates of hand washing. So knowing what's gone before, what works, really helps to hone down your own ideas for how to improve quality locally. Well, finding the relevant research, I mean, it can be overwhelming, particularly if this is something you're not used to doing. And it's very important when using some of the research databases that you're very clear about your search terms and therefore which studies are going to come up when you ask the database to search for hand washing improvement. So really try, if you're not used to doing this, enlist some support from somebody who's used to working in research. Most organisations do have research leads, people whose role, whether it be in your medical library or elsewhere, whose job is to help people understand how to use the search engines effectively. And so some sort of really quick tips is that it's a good idea to look for systematic reviews, because a systematic review will already have compared several studies on the same topic to see how their results compare against each other. And then if it's an area where a lot of research has been done, you may also find meta-analyses. So as I say, work with your local research leads and start just getting a bit familiar with what's out there and how to find what you need. And another tip is to sign up for regular research updates. There are lots of these around. Lots of clinical areas will have a research scanning service. Here's one that I use, for example, the Health Systems Evidence monthly email alert system. This is done by the great people at McMaster University in Canada. And so this is particularly about improving health systems. And you can see on the screen there that this month's notification had some hot documents, effects of interdisciplinary team care interventions on general medical wards. And so, for example, that is a systematic review, another systematic review, and then the third bullet down, rapid response systems. A lot of health services have introduced rapid response systems, so that when a patient is deteriorating, there's a system in place to try and get the right help there. And this is a systematic review, and that's also a meta-analysis, so they've also been able to review some existing systematic reviews. And there's this sort of information is available across many clinical specialties and areas of healthcare improvement. Other sources which are being developed to help people share information and get more information in the areas of improvement that they want to work in are good practice repositories. So two that we use in the UK are from NICE, the National Institute for Health and Clinical Excellence, who have quality and productivity, what they call proven case studies. And also the BMJ has started in recent years to do a quality reports service. And I think you'll find that other national patient safety and quality improvement agencies are doing similar sorts of services. So it's where the report is perhaps not of a standard, it's not quite in the research field, but people have done some improvement work, tested it and measured their results, and have got a credible quality improvement report, but these are being collated so that others can learn. So just to, again, show you what it looks like, this is the landing page on the NICE website if you ask for the evidence service, NHS evidence, and the quality and productivity case studies. And again, they are listed, and you can search within the list for different types of clinical practice areas or different types of approaches. So you can see here that they're mostly classified by the sort of clinical practice, so chemotherapy or pharmacy, decreasing risk doses. So again, you can get into this by clicking on the title, and what you then get is a downloadable PDF, which is the case study, and each of these have been reviewed they've been peer-reviewed by experts in quality improvement and health economics to ensure that they are robust, that they have included information to show whether savings have been made, whether they've got measures of how quality has improved. So all the studies are graded, and as you go into it, as you go through this PDF document, it has quite a detailed description of what's been done in that study and how the team did it, and for example, how long it took them to implement the change, which is another important facet, because if you're wanting to do something and see a result within 3 months, you don't want to try and replicate something that took another site 3 years to put it in place. You want to have an idea of sort of how much time and effort is this going to take. So these are very useful. It's not very extensive. There are there's a few hundred case studies there, but they are well written and clear to follow. And this is just to show you the BMJ Quality Improvement Reports page. So again, quality improvement studies are listed there. You can just browse by topic, click on the Browse by Topic button, and again it will take you into certain clinical areas. You do have to subscribe to this service in order to put your quality improvement report, submit your quality improvement report for review and to try to get it listed. But in terms of just looking at what's on the website, that's all freely available, and you can go to that website and have a look to see what's been done. Are there any ideas that you can pick up? What's already out there and reported in the area that you've identified where you want to do some quality improvement work? So that was just a quick overview of some of the ways in which you can start to sort of get to grips with what is the evidence in the area that you'll be looking to work in and carry out your quality improvement work. So at this stage, I'm going to hand over to Juliana to do our first poll and understand in the audience to what extent you are now using, have been using research evidence.
Thank you, Helen. So the poll has been launched, and the question stands as follows. To date, has your improvement work been based on research evidence? And the answer options are yes, totally. Second, yes, to some extent. The third, no, we generate our own ideas. And the fourth, not sure. The audience is already voting, and 50% of our participants have already voted. So we will give them a bit of more time, and we will display the votes. So 75% of our participants have voted. Perfect, and we will display the results now. So we have 17% that opted for option number 1, yes, totally. 71%, so majority of our participants went for option number 2, yes, to some extent. And then we have 7%, no, we generate our own ideas, and 6% not sure. Over to you, Helen.
Great. Well, thanks very much for doing that poll. I mean, that's really interesting to see those results. So that's very very reassuring. Really good news that 71% of people are aware of the research evidence and are using research evidence when putting quality improvement work in place. And just wanted to sort of, for those of you who perhaps not doing that yet, just run over the benefits of doing research-based improvements. As I've said, it means that you're not starting from scratch. There'll be some written up studies of what people have done, how it worked, what measures they used. So you've really got a very good idea of where to start from, and perhaps how you can improve on what people have done, or if it looks very successful and you think you're in a similar sort of setting, how you can replicate it. It also means that if you've got those research results, you're able to, not formally, but you have a benchmark, so that as your quality improvement intervention is getting underway and you're starting to see your data, you get a sense of how you're doing compared to how others have been able to use that intervention. So that really helps you to see, are we doing as well as expected, as well as others have with this intervention? It's not really working as well as perhaps it could do, and what can we do to improve it? So that's really useful. And the third one, the inevitable question from clinicians when our bright-eyed and bushy-tailed quality improver goes to meet the clinicians and proposes a new intervention, a change to practice, and you get the question, what's the evidence for this? And there you are. You have the evidence, you can quote from the studies, you can refer them to the papers for further reading, and provide results from peer-reviewed journals. So it just sort of gets you off to a very credible start in terms of taking others with you on the quality improvement journey. So I don't know how many people get the reference, but the evidence is out there. It really is. There is not for everything. There's lots more that still needs to do. There is lots of innovative work which won't already have been written up, but there's a lot of evidence out there, but we do sometimes almost willfully ignore it, or genuinely are unaware of work that's been carried out before. So I think it's just to get to reinforce the idea that it's out there, and it's up to us to really make good use of it. So now I want to move on to the second part of this webinar, which is about doing the improvement work in a more scientific way, using research methods to underpin the way in which we implement quality improvement changes, and trying to make sure that these are based on evaluated methods with an explicit theory about how and why the intervention is expected to work. So you may have seen this cartoon before. It does get used quite a lot. But it's so good, that's why people use it such a lot. It really makes the point. We have some equations, we have some theory, then a miracle occurs, and we're on to the results. And the professor is saying, I think you should be more explicit here in step 2. And this does make a very important point about the missing middle, the black box, where too often we have a method, we see a report which tells us that the organisation was looking to reduce prescribing errors. They had some ideas about how to do that, had a plan for an improvement intervention. We implemented the intervention, and here were our results. But we don't really learn anything in that about how the implementation went, and often results are not presented in a very robust way. So this is all about understanding the theory. How do we expect the intervention to give us the results, and how have we measured that to show that the two are linked? So this is the idea of a theory of change. And it's essentially a comprehensive description and illustration of how and why a desired change is expected to happen in a particular context. It is focused on mapping out what's being described between the components of an improvement program and the outputs that are achieved, and how those outputs are expected to lead to the desired goals. So when developing a theory of change, the idea is to first of all identify the desired long-term goals, and then to work back from those to identify the conditions that must be in place, so what are the outcomes that we're looking for, and how those are related to one another, what causes what in order to reach the goals. So in order to explain this a little bit more, we've put together quite a simple theory of change for some grouped interventions which would be aiming to improve the management of chronic conditions, pain, fatigue, shortness of breath. So as we look at it, over on the right-hand side of the screen, we see our goal, which is behaviour change, which means that chronic conditions are more effectively managed. So that's the goal. And then we're asking, okay, so in order to get to that goal, what sort of outcomes do we want? What means, how do we know that those conditions are being better managed? And so we've identified some of those aspects. So first of all, making sure that people have got access to the right interventions. We think that if they undertake the activities and the outputs from those activities should lead to needing fewer visits to the surgery because their condition is more effectively managed. We might look to hoping that there would be a reduction in medications over time, and that individuals feel more empowered, that is, they feel more in control of that long-term condition. So those are the outcomes. And then we have some quite closely linked activities and outputs. So this group of healthcare professionals have then said, okay, if those are the outcomes we want for our patients, what sort of activities do we need to put in place that we hope we would get to those outcomes? And they've thought about things like running pain clinics, having a psychotherapy service, having physical activity workshops, dietary and nutritional advice, smoking cessation workshops. So those things in the red boxes are all the activities that they're going to put in place. And they then lead to some outputs, which means that people, they're able to see a higher number of self-referrals, that people are able to have more understanding of their emotions and therefore better able to cope with and reduce the effect of their pain, that they are more alert to how their condition feels and when that's getting worse and the action that they need to take, so recognising and reporting the adverse effects, and then be more accurate in how they then self-administer their medications in response to that. And would hope that the dietary and nutritional advice, together with smoking cessation and physical activity, would all help to lead to lower BMI. And what this group of clinicians have also realised when they're thinking about those activities, all the things we want to do with patients to help them manage their condition, is that there's a precondition before they can work with those patients. They're going to need an advertising campaign so that people come forward and take advantage of this new range of activities that they're putting in place. So it's a way of systematically going through the stages and particularly aiming to make the links between, if we do this activity, it has this output. Start to think, well, at what stages can we measure some of these things? What are the outcomes for the people experiencing those activities and the associated outputs? And how is all of this helping us reach the goal? And then around the actual steps of the quality improvement work, there need to be some enabling factors, which is this list on the right of the screen, bottom right, the enabling factors, so that they're always thinking about who needs to be involved, who are they trying to reach, and understanding that before they start. So therefore, where is their advertising campaign, what channels are they going to use for that, who needs to be involved locally, what funding do they need, and that monitoring and evaluation needs to be in place so that they can measure and monitor all of this and see whether the change is happening as they expected it to. So that's a fairly simple theory of change, but it's a good idea to try and keep it simple, try and sort out which are the key components of the intervention. And so the advice would be to keep it simple, try to use language that everybody's going to understand, not lots of clinical terms or lots of research terms, but everyday language. It gets hard if you're doing something multifaceted and quite a complex intervention to meet the advice to keep it on one side of paper or one screen view. But that's the way in which the schematic and having a diagram will work if you can see it in one view. It needs to be really focused on the key elements, and the relevance is to systematically explore the assumptions linking the action and the expected outcomes. And we don't see it as a, do it once and that's it, you've ticked that box in your quality intervention. Return to it at regular intervals. See what's changed during the implementation and really understand, does the theory, does it work in practice? Do those links that the assumptions made, do they hold up? Did people attend the physical activity workshops? And did that work to help lower BMI? And it may or it may not. Sometimes, certainly exercise alone is unlikely to do that. So you need to keep following up and checking the assumptions. And as we said, a key part of this is to measure. A famous quote from one of the early gurus of quality improvement, H. James Harrington: measurement is the first step that leads to control and eventually to improvement. And this very much explores the idea that unless you measure, you absolutely can't say whether there has been an improvement. You have to know, where did we start from? Baseline data is absolutely essential. You can never recapture the baseline data once your intervention starts happening and starts taking effect. So it's a really key part of the planning to define your measures and how are you going, what to measure, what are the key things, what's going to be relevant, what's maybe not so relevant to measure, and how are you going to measure it. It's very useful to use routinely collected data. However, you may find that data that goes into an organisation-wide system, it can't always be kind of got back when you want it back. It may not be as accurate or as timely as you need it to be in order to inform what you're doing with your quality improvement intervention. But if you can use it, that's great, because then you're reducing the burden. And this is one of the things that frontline staff often do complain about with quality improvement work, that there's an added burden of extra data to be collected, extra forms to be filled in, extra paperwork, and they feel it's they're putting in a lot of effort, and you need to be really sure that is going to pay off. Very important to measure over time, and we would recommend that you use robust techniques such as statistical process control chart, because that's using statistical process control. I mean, it's a subject in itself, won't go into it now, but enables you to understand when you're seeing variation, is it just routine variation or is it special cause? And if it's special cause, is the cause that's perhaps driving it in the direction you want it to go, is the cause an element of your quality improvement intervention? So here are just some typical measures that you will be familiar with. So we have process measures. Typical ones are things like prescription errors, compliance, such as completing a checklist that's been introduced. Clinical outcome measures are, of course, really important, and they're the bedrock of what we're trying to do, is to improve the outcomes for patients. But there are lots of other things that you can measure as well as clinical outcomes. In a way, we'd say don't just jump straight to outcome measures, because sometimes you may need a really large sample of patients and a long time to know whether there's actually been an improvement in clinical outcomes. So think about what you can measure, where you're going to get the data, Do you need to measure the resources that you're using? Are you hoping to show a reduction in length of hospital stay? And of course, really important to understand how is your intervention affecting the patients, and what measures do you want to use there, and do you have a questionnaire that's already measuring that, or do you need to introduce a new questionnaire, and again think about how to administer that. So the other important aspect here is that you need to ensure that you're actually measuring the thing that you're changing, because none of your quality improvement interventions are happening in a vacuum. You're working in a complex system, things are changing all the time, and you need to be able to show the causal link between the changes in your measures and what you have been doing. So all of your measurement comes into being part of your evaluation of a quality improvement intervention, and a lot of this will be self-evaluation by teams carrying out the implementation. And your key question is always a variant of, did the improvement intervention fulfill its intended objectives, with some sub-questions around, this is the middle bit, how was this achieved, what resources, and very important, what unintended results. So for example, if evaluating, the objectives need to be closely linked. When you're looking at how you're going to evaluate, you need to closely link your questions to the elements of your intervention. It's the same as your measures. If your evaluation is jumping straight to looking at patient outcomes, what you're doing may not be directly enough related to the patient outcomes. It may be affecting some part of the system that's a bit removed from patient outcomes, so you need to look at some proxy measures. So for example, people attending smoking cessation sessions, rather than looking for an immediate effect on the outcomes, patient outcomes for people with COPD, for example. So sort of looking at sort of what's close to your intervention. There are a number of different evaluation approaches. I'm only going to sort of cover this really, really quickly. Most will be a combination of summative, so that you do have some conclusions at the end of what was the effect of the intervention. But it's very helpful if you do this in a part of it is formative, and you're looking at your findings as you go along, and that helps to shape the intervention. And then there are two particular forms of a formative evaluation: the rapid cycle evaluation, which is aiming to really frequently review effectiveness and see what changes may need to be happening in the intervention, and developmental evaluation, which is very much intended to shape the intervention itself, so that goes alongside, or that starts really at the planning stage, and the developmental evaluation informs every stage of how you plan that, what sort of measures you use, and making sure that you change those frequently. You may be part of a large-scale evaluation program which has had a commissioned external evaluation. This can feel a bit like you're being under scrutiny. Very often it would be a team, a specialist team from a university or a specialist consultancy. They'll be very experienced in evaluation methods. And you can feel that you're being tested as to whether you're doing it right. But really say, it's a great opportunity to learn. Such a team will be able to give you really good insights. They'll be able to do detailed analysis of your data and sort of qualitative insights they can get about how or why the intervention is working can be invaluable. So do say, don't feel defensive. Try and share your experiences with an evaluation team, and really make sure they get the full story, what's going well, but also the challenges. Just want to highlight that you can download our short guide, Evaluation What to Consider, free from the Health Foundation website. So now we're on to our second poll, and over to Juliana.
Thank you, Helen. And we will launch our second poll now. You should have it on your screens now. And the question stands as follows. Do you think it is important that quality improvement work is written up for publication? And the answer options are yes, no, and not sure. 65% of our participants have already voted, and we have a dominant answer this time. We'll just give a couple of more seconds before we display the final result. And we are displaying the result now. As you can see that 93% of our participants have opted for option number 1, which is yes, 1% for no, and 5% for not sure. Over to you, Helen.
Okay, well, that again, very encouraging, and really pleased that you are wanting to help build the evidence base. Just credit for this next section of slides is based on presentations by Pavel Zhizhania, who's editor of one of the key journals in our field, BMJ Quality and Safety. And he gets a lot of quality improvement reports, which he says, frankly, you can't really use. They're not robust. They're not written in a credible way. So here are some tips that will help, we hope will help spread successful improvement interventions and prevent wasted effort. So what do we want to see in it? We want not only the results, but all these other components as well. I won't read them out, you can see them, but it's the sort of thing I've already been talking about. We need to know how it was designed and where implemented. That's the context, because that makes a lot of difference. What is in a small community hospital or a huge teaching tertiary care centre? Absolutely clear on what were the core components and the measures, and really how it all works. So that's what we want to know from a quality improvement report. As I said earlier, of course, there does tend to be a bias that people are much more inclined to write up and submit a paper when they deem that their work's being successful, but we can learn an awful lot from what didn't work. And this is the editor's complaint, that many of these reports are really, hey, look, we did X, as opposed to, here's what we have to do to achieve X. And I always say that only your team and perhaps your family and close friends are interested in the first one. The second one, what we had to do to achieve it, is of much wider interest. So in order to facilitate spread of successful approaches, we need to believe from the report that something has worked, and we need to understand enough about it to know whether it's worth trying to replicate. So what are some key problems here? Well, too often you're reading the report and you're reading it going, okay, so you had this idea, but what did you do? And I find myself thinking that a lot at presentations and reading reports, thinking, well, but what did you actually do? So you don't really know if it's worth trying because we can't understand quite what the people did. And also there's no information on the barriers or problems because this is writing a success report. But that really reduces the credibility. If we're working in improvement, we know that this stuff doesn't work first time. And people will just ask, gosh, how did you get your clinicians to change from doing procedure X to procedure Y? Or really go, really? That checklist worked straight away and you've got these levels of compliance. They don't lose. So we really want to know, what was done and how was it done. So here we see a very abbreviated but typical QI report, briefly stating the issue, hospital infections, that staff don't wash their hands. We implemented a multifaceted stress strategy. They have managed to improve hand hygiene by 50%. Important, we need to know by 50% from what to what percentage. That could sound like a great result, but actually be somewhat unimpressive if you got right down to it. And then at the end we say, oh, patient empowerment can be effective. But what we haven't got here is we haven't really got a connection between the facts that we have a problem with hospital infections and that hospital staff do not wash their hands consistently. But there's no real link is made to understand how did the staff education or the clinical champions really work to encourage staff to increase hand washing. So if we try a different approach, we then say that we identified, commonly identified barriers were A, B, and C, and then understand how the components of our intervention addressed A, B, and C by doing X, Y, and Z. And so this is taking us back to the theory of change. This is the theory for the intervention. Why did these ingredients in it achieve the results? And then what did you do? And too often we get mention of quality improvement techniques, but again without really saying what we did. So PDSA, without any understanding of what was the plan, what did you do, what did you study, and how did you act in response, doesn't really tell us anything. 3 cycles of PDSA, and there's also been very interesting research showing that people think they're doing PDSA but actually don't follow through the whole process and the way it's designed. So again, we try to understand what was the feedback that you got. So it was reported that timing of training sessions was an issue, so they couldn't get staff attendance that they needed. So in order to address that barrier in their quality improvement approach, they worked more closely with the managers, and it's implied, but in the full report you'd want to say what time did you change it to and how did that happen, and then something about their training materials, that people wanted more visual material, and so that was developed with staff. So we're learning much more rich detail here about how did this organisation make this work. So what to consider when you need to start writing up? How are you going to capture those key components? And when barriers arise, how to overcome them? So I think we've all been aware of that writing up job that gets put off and put off. It always takes longer than you think. It's so important to start this, really start from the planning stage. And it's the same as not being able to recapture that data unless you've done it from the outset. Unless you're capturing the story of your quality improvement through your planning stages and the meetings that you have, and as you make changes and adjustments to it, it's sometimes very hard to remember what did you do at the end of it when you think, oh yes, you know, we've got our results and now we're going to write this up for publication. Unless you've done some work contemporaneously, you're kind of reinventing history, and it's hard for that to really be accurate and to really, it's not that people don't want to report the barriers, but actually once you've changed something and it's working successfully, there is a tendency to think that that was how you always did it. So terribly important to capture this, and an improvement diary is just one approach, but you may have very good action notes from your project, meetings and so on, but make sure you do keep all of those. Very often we get reports that are written up by the improvement lead, and perhaps with somebody who's doing this as part of a research project, perhaps writing it up as part of a PhD or a master's course or something. That's great because they will have a great investment in wanting to do that and do a good job. But you're only getting one perspective, and really important to involve the other people who were involved, really understand how your improvement initiative has affected people in other departments, upstream and downstream with a particular part of patient care that you've been working in. And that can help you, that can be crucial in terms of making sure that the change is sustainable, is understanding what's happening before and after in the patient's journey. And service users are, of course, vital, because this is why we're doing quality improvement. And if the intervention isn't working for the service users, it isn't working. You need to think about where, who's your audience, where to publish, and key information remains the same, but it's going to be different as to where you decide to publish. And whilst the peer-reviewed journals are the most significant in terms of building the evidence, you might get more take-up if you put this into more of a sort of professional practice magazine. It just depends what you're trying to achieve, and of course you can do both. You can do different styles of articles to get to both of those audiences. And in today's world, it's terribly important to think beyond text. The old adage of a picture's worth 1,000 words, and in terms of getting people's attention, something on Facebook, Instagram can really grab their attention, then you can signpost people to the written material which has more detail. In terms of thinking about how to structure this, which can be very difficult, particularly when it's not your day job, writing reports to publication, are the ISQua guidelines. The standards for quality improvement reporting excellence. And these were first developed in 2008 and have been used extensively since. And they've just been reviewed after a lot of consultation with people using them and trying to make them more user-friendly. So it's a checklist of points to consider when you're writing up. But as with writing up altogether, we'd recommend don't just reach for the ISQua guidelines when you're at the point of your final results are in and you're ready to write up. This can really be a useful planning tool as well, with the prompts that are given for what you need to think about and the sort of data to capture. So again, just to let you know that it's all available to download from the ISQua website, just to be all being updated as well, along with the guidelines. The guideline on the website looks like this, and all of that blue type provides links to further information and guidance. So it has been designed to try to make it as easy to use as possible. And there's the website, isquastatement.org, or of course you can just Google ISQua guidelines and that will take you straight there. So, dissemination of results is a really important part of the quality improver's role, but it is one that sometimes gets forgotten. Part of it is quality improvers, we love to do things. We love to run on to the next thing, we're action people, but dissemination is really important. So do think about different channels to use, the opportunities that you have to spread your work, and trying to use these effectively so that others will know about your successes, or very importantly, something you thought seemed like a good idea, in fact didn't work as well as you thought it would. So here is the conclusion of my talk. Really, people say they are already very much using the evidence base to plan your improvement work. So continue to do that, and let's try and get everybody using the existing evidence. It's all out there, and with a bit of practice, it gets much easier to find it. When you're doing improvement, actively use the robust research methods that underpin evaluation, thinking about what data and measures are going to give your results credibility and enable you to demonstrate that there has been a change. And when you've got your results, think about how you write those up effectively so that you can contribute to building the evidence. So that concludes the formal talk, and now we're open for any questions.
Thank you, Helen. Thank you for this exceptionally formative and practical presentation. Obviously, it is a very current subject matter, as we have an impressive number of participants who join us today. We have a number of questions, and the first one is from Neil Chadbourne. And the question stands as follows. Is it a problem extrapolating from research setting to a practice setting? For example, research setting is often a closed or constrained environment, and many patients are excluded from studies. So this may set the bar high for the benchmark.
Absolutely, and the questioner has taken us straight to the nub of improvement research and the importance of context. And so you're absolutely right. Research, clinical research, will very often, as you say, have had a very selected group of patients who were involved in the study, very, very strict exclusion criteria, and will be very, particularly if it's a study of a medication, it will be very controlled, and the medication is, we know, is the same medication that every patient is getting. And this is where improvement work is different, in that context is always part of the improvement. So I think we need to be careful about making sure that the sort of research that we're using to base our improvement efforts on is very much from the improvement research body of work, where people will have been doing this work in a live clinical setting within a healthcare system, and they should be able to describe that context in a well-written report so that you understand enough to think, is this very different from where we will be trying to do this intervention? Was their patient group really different from ours, in which case we may not have the same results. So it is really important to think about to think about the context, to understand where was the original research undertaken. But we're not really talking about introducing a new drug therapy when we're talking about quality improvement. And so the setting, it's never happening in a vacuum. There's always lots of other things happening around that health service context.
Thank you, Helen. The next question is from Yasser, who is the new participant to the fellowship program, and it's actually his first ISQua webinar. So his question is, which type of publication would have a stronger impact, or if I may say, strengths of evidence? An article published in a peer-reviewed journal that illustrates a QIP, or a published quality report like the examples you mentioned in an ICE and BMJ reports?
That is a very good question. I think in terms of something innovative, something where you've tried some new approach, and you feel you've got quite a robust research and have used good research methods to undertake it, I think it will tend to have more impact in a peer-reviewed journal. But where you are reporting work that it's quality improvement work, you haven't really attempted a new method. You're really talking about some successful applications. Say, for example, you've done a successful project which has introduced some principles of lean to how you're running a pharmacy. It will be quite hard to get that published in a peer-reviewed journal because you're not doing anything that's methodologically new. But in terms of the nuts and bolts of how you were able to do that in the pharmacy department, will be very useful to publish as a quality improvement report. So it's like all of these things. You need to think about how much was this original research, and is this some implementation best practice or something that worked that you're wanting to share, or is this something novel? Is this something that's really taken our understanding of the methods and how to use them further? And I think some projects will lend themselves to both, and then you're hitting both audiences. I would say there's still more people probably looking at peer-reviewed journals than are looking at best practice repositories. The nice quality and productivity reports and BMJ quality improvement and other similar types of repositories really need to sort of do more to get better known and have more people using them, so you'll hit a wider audience through those.
Thank you, Helen. The next question is from Mohammed Al-Nafili, and he's asking, what are the differences between the quality improvement methodologies and research for improvement methodology?
Okay, another excellent question. I mean, this is quite subtle. If you're using a quality improvement methodology, the idea is that you are using something which has been researched, and therefore you're basing what you're doing on the research evidence. So you have good information about how and why this should work, and then it's a question of carefully implementing that. But when you're doing quality improvement research, you're trying to understand more about how the methods work, what do people do when they try to implement a quality improvement methodology. So there is a subtle difference there. One is about using the methods while you do the work, and the other one is about studying how you do the work. So I hope that's clear. It is quite subtle, and they're both really important.
Thank you, Helen. The next question is from Stephen Balagoon, and he's thanking you for this great presentation. And his question is as follows. He's conducting 2 QI projects and would love to know examples of journals that are readily available for publication of QI projects from Africa.
Okay, well, I think the journals are, particularly in our field of quality improvement, the International Journal for Quality Improvement in Healthcare, and BMJ Quality and Safety, which I think are two of the top journals in the field. They're certainly the ones that I tend to turn to. They are looking more widely across the world for example, for the sort of studies that they publish. I think they're not taking a purely sort of Western high-income developed countries perspective. But the key thing for publication in a peer-reviewed journal is in terms of showing that you have done something novel, that you've taken the work further, that you are testing a new proposition, and it's not just reproducing work that's already been tried and tested elsewhere. So there's nothing wrong, and we absolutely want people to implement work that has been tried and implemented elsewhere. But as I was saying, that's not what the editor of a journal, a research journal, is looking for. The key thing here is that there has to be some an interesting research question which is helping to take the thinking further forward to get published in a research journal.
Thank you, Helen. We do have a number of questions. I'm not sure whether we would have time to go through all of them, but we will do our best to answer at least majority of them. So the next question is from Dominic Furniss, and his question is as follows. Measurement is often associated with quantitative techniques. Do qualitative methods have a role to play?
Absolutely. As I said, we usually see that quality improvement research is most often it's mixed methods and it involves some quantitative work and some qualitative work. The qualitative work is very important in giving the insight into that missing middle, the understanding how did we get these results. The quant is to show that you've got very robust results, that your quantitative analysis has got the right sort of statistical power, that you've been very exact in terms of how you've defined things like, definition of denominator, for example, in a statistical analysis is terribly important, and that's quant methodology. The qualitative comes in understanding how and why did people work in a certain way. And I would sort of point you to one of the best studies in this area is by Mary Dixon Woods, Professor of Medical Sociology at Leicester University, and her paper in, I think it was in Millbank, which basically took apart the Michigan Keystone Initiative. The Keystone Initiative was a very successful quality improvement program, which showed how intensive care units in the state of Michigan had very significantly reduced their incidence of central line infections. And so they had great quantitative data that showed that without doubt that number of infections had gone down. But Mary's study explained a lot more about how they had been able to do that successfully and how people had found working with the collaborative and what had been the benefit of doing joint training and the importance of the local leaders regularly getting together to share their results. So this was all the qualitative work that helped us understand why that had been so successful.
Thank you, Helen. The next question is from Andy Mitchell, and he's asking, do you have any tips for sustainability of the quality improvement processes, especially in the context of current measurement and improvement overload in the NHS?
Wow, these questions are very insightful today. Absolutely, it's really difficult to sort of keep telling frontline staff that yes, we've got another initiative and now we're going to be doing this, so this is going to help you improve, all of which can actually get very wearying to people. One of the great mantras is to make the right way the easy way. So, for example, if we're trying to introduce clinical care that follows a good practice guideline, rather than producing loads of documentation that tells staff how to do that, think about all of the practical nudges which will help people, in fact, follow the guideline, so whether they know they're following the guideline or not. So we've seen really good examples of having a guideline for in obstetrics care, reduced to a sticker with some simple points of data and questions that need to be answered on the sticker. And as long as you complete that sticker on the front of the notes, the staff will be implementing that part of the good practice guideline. So it's always thinking about what makes this easy, what makes this something that fits the routine, it's not something to add to the routine. And that is, it's hard work to do that and to get something really slick in place, but it will really pay off rather than introducing yet another unwieldy either bit of paperwork or another whole set of computer screens that have to be completed. It's that sort of planning up front, how to make this fit with the way that people actually do their job, rather than some theoretical way in which they do it, and rather than adding lots of steps. So if you can think about stripping out some of the things that perhaps you don't want people to do anymore as you introduce the new thing, that might be one approach to this.
Thank you. And the last question for today, although we have still a number of them outstanding, would be from John Biabagambi. He's thanking you for this excellent presentation, and he's asking you advice on that the most journals want information on ethical approval, yet we do improvement work during the day-to-day work and write up the results. So there is no formal process of protocol review. Could you please advise on what is the best practice to approach this?
Yeah, that's a question we often get asked, and certainly I can't speak for other countries, but here in England it has been recognised that doing service improvement work does not require ethical approval. As you say, it's improving the day-to-day work of the service. You're not usually providing some different treatment for a subgroup of patients in the way you would be in a clinical trial. So many of the journals are now, they recognise this, and so there used to be a real problem with getting published if you didn't have ethical approval. But you're quite right, you're still wanting to do some research, you're wanting to measure this and know whether this improvement is working, and so a review of your research protocol is really useful. So there may be, some organisations may have research approvals groups which will still do that review, even though they understand that it's not a question of seeking research ethics approval. Another way would be to use peer review techniques, so just to use your networks of researchers and get somebody external to review the protocol, so you have that informal approach. But absolutely, it's very wise to get somebody else who's not gone through all the thinking and involved in all the detail that you are, but somebody with the right expertise to just check that what you're proposing looks like a credible and sound approach to the research.
Thank you, Helen. We have so many questions that we probably need another webinar to follow up on all of them. So we will work in conjunction with you and see whether we can do a follow-up session and just take into consideration that the questions that were posed. Thank you, everybody, for asking them and being a wonderful audience. And thank you, Helen, for a brilliant webinar. It's extremely useful presentation, as you can see, to our participants, judging from a number of participants attending and the number of questions being asked. So just to let everybody know that the recording of this webinar will be available on the ISQua website within 24 hours of the actual live webinar taking place. So if anybody who would be interested in the information from this webinar, it will be freely available on the ISQua website. Once again, thank you, Helen. Have a great remainder of the day, and thank you all participants for joining us today.
Thank you.